the substantia nigra. And what these neurons or these brain cells are tasked with doing is producing dopamine. And then it sort of shoots up that dopamine to the higher centers of the brain that are outlined there that we call the basal ganglia. And they sort of bathe the basal ganglia in dopamine in order to allow us to have nice, normal fluid movements. So this dopamine is the really crucial chemical in the brain or neurotransmitter that allows us to regulate movement. So when we have loss of dopamine, as what happens in Parkinson's disease, the movement becomes disrupted. And so we see smaller, slower, basically loss of movement. So as you can see, that's a normal, healthy neuron on the left that's bathing those receptors in those dopamine little molecules. And then on the right, there's the Parkinson's disease where we're having less of that dopamine. And then all the way on the left, there's a picture of what we can see at autopsy of that area of the brain called the substantia nigra. And you can see in the normal, there's that nice dark pigment indicating that dopamine is being produced versus what happens in Parkinson's disease. Those cells die off in that area. So why do the cells die off? That leads us to the next question. Well, that leads us to a protein called alpha-synuclein. And this is a protein that is in all of our brains. It's a normally produced protein that allows for healthy regulation and maintenance of our neurons or our brain cells. But for reasons we don't quite understand, this starts to misfold and clump up. And as you can see, the end result of that are these clumps called Lewy body inclusions. And that's an actual picture of one under the microscope. That kind of purple, hazy, round ball is alpha-synuclein that was supposed to be functioning normally, has now clumped up. And it's a marker for Parkinson's disease. So we think that clumping of alpha-synuclein may lead to cell death of these dopamine-producing neurons. Now we can see this alpha-synuclein in other parts of the body, and that may allow us to find a biomarker or a test that we can use to pick up Parkinson's disease maybe much earlier on, or to help in those cases that we're not quite so sure, the picture isn't 100% clear. So we don't have a blood test currently, but it's certainly being studied. And so right now, we're not quite sure that it has enough power in order to detect everybody that has Parkinson's disease, while also not giving us false negatives and telling people they've got Parkinson's disease when they don't, because we definitely don't want that to occur either. So this is something that we are looking forward in the future that will help us catch Parkinson's disease sooner and then potentially change the course if we have a medicine that can change the progression. So what causes those dying off of those neurons, or why does this alpha-synuclein clump up? Well, that part we still don't know. So Parkinson's disease was famously first described in the medical literature by James Parkinson, hence why it's called Parkinson's disease, back in 1817. So we're over 200 years later, and we're still not sure what the exact cause is. And it's likely because there's many combination of factors involved, and it's probably because it's different for everybody. So let's talk a little bit about genetics. So the genetics of Parkinson's disease is pretty interesting. And we're really in our early stages of understanding, with the first genetic Parkinson's described, only in the last 20 years. Before that, we said, probably not a genetic disorder. But it was noticed as that we see these families that seem to pass down this Parkinson's from generation and generation, and finally, once genetics got good enough to detect different mutations, those started being described. So I know this graph is sort of messy, but I just want to break it down a little bit. So on this left side, you can see there's a group of genes here, and it's not really necessarily important you know their names, but we see these group of gene mutations, which are very rare. Very few people have these, and that's probably less than 10% of people with Parkinson's disease. But if you carry this gene, you're at a very high risk of developing Parkinson's. It's almost a foregone conclusion you will develop Parkinson's disease throughout your lifetime. And then on the other side of the graph, we have these genes, which are found in many, many people. I mean, all of us in this room may carry some of these genes and never develop Parkinson's disease. But when they look at large groups of people and study them, they see these genes come up over and over as risk factors for development of Parkinson's disease. And so these are genes that are very low risk, but they're very common in the population. And then you have the kind of the group of genes that are in the middle where there is medium risk and medium frequency. So again, just showing you how complicated the genetics are with this disease. What we do understand is that probably about 90% of Parkinson's disease is not genetic or easily found, that there's one gene causing the disease. So it's a fairly common misconception that I hear from people saying, well, I don't have Parkinson's in my family, so how did I get it? Well, the vast majority of people with Parkinson's do not carry one of these genes. I do want to mention a study called PD Generation that's put on by Michael J. Fox and the Parkinson's Foundation, and some of you may have heard of this or already had this testing. So it's a national initiative because we want to better understand genetics in Parkinson's disease so that we can go about trying to cure it. And so what this is actually an in-home evaluation. You don't have to travel to one of the sites that are doing it across the United States. And they do like a cheek swab. And you send it in, and then you can meet with a genetic counselor and talk over the results of that. And they test for the 7 most common causes of genetic Parkinson's disease. So as of this summer, greater than 10,000 people in the United States have been studied with this over the past few years. And they found about 12.7% had a genetic form of Parkinson's. So the goals of the study is to accelerate clinical trials for Parkinson's disease, improve Parkinson's care and research, and empower people, giving them knowledge about that you have a genetic diagnosis that could be passed down. Now, the way to access this is literally Googling PD Generation, and it is the first thing that comes up. And again, it's through the National Parkinson's Foundation. All right, shifting away from genetics to things that we're exposed to. So older age itself increases your risk for Parkinson's, so there's something happening as we age. The male gender, again, something we largely don't really understand, is why men have a 1.5 to 2 times higher risk compared to women for developing Parkinson's disease. And then a lot of things that we are trying to understand about environmental and chemical exposures, but we're definitely seeing associations in study after study of different herbicides and pesticides, solvents and cleaning chemicals. I have listed tetrachloroethylene. There's also trichloroethylene, and that was as part of the study that was announced earlier this year about Camp Lejeune and the increased risk of Parkinson's many years later. So people that were exposed to these chemicals, and then they followed them for 30 years, and now we're seeing Parkinson's at a higher rate. Head injuries also increase risk for Parkinson's. And then interestingly, smoking and coffee consumption has been consistently across studies been associated with a lower risk of developing Parkinson's disease. Now, this doesn't mean that we're encouraging people to pick up smoking if you have Parkinson's disease or to start smoking, but it's just an interesting thing that has been noticed. So overall, what's causing Parkinson's, for most people, it's probably a combination of some of those genetic factors that are lower risk. But if you have a few of those genetic factors and then you have a few of the environmental exposures, if those hit in the right sort of time, then it may cause Parkinson's disease. And so some people's circles may be farther over toward the genetics, some people may be farther over to the environmental. And that sort of I think lends itself to how Parkinson's is so variable. So it's a mix that's different in everybody. And that also lends to how we see the progression in Parkinson's, because this can be very, very variable. It's a common question that I get is, well, how will I be in 5 years, or how will I be in 10 years? And it's an impossible question to answer because Parkinson's is just so very different. There's a saying that if you see one patient with Parkinson's, you've only seen one patient with Parkinson's, because everybody's disease is so very different. So I wouldn't be able to tell you, exactly where you'll be at in X number of years. Now, this is a Hoehn-Yauer scale that's mentioned here, and this is just sort of one way to think about the stages of Parkinson's disease, and it's based upon the physical ability, so having one side affected, then both sides, then having some difficulties with walking and balance. And I think it's okay. It's probably better for research than it is for talking with patients about their symptoms, because one, you can sort of change where you're at depending on how well your medicines are working. And so some people might be a stage 3 when they're off meds and be actually stage 2 when the medicines are working. So I like to think about the progression a little bit more in terms of this. Again, they put the year timeline on the bottom, but it's more of an estimation. So we can have years before the onset of the actual physical signs of Parkinson's, things like constipation or that REM behavior disorder, and even some mood changes. And then the signs of Parkinson's show up. And then, again, this is a generalization. Some people may be in that kind of early stages for many years, and some people may only have a few years before we start seeing more of the non-motor symptoms or some of the neuropsychiatric difficulties like the memory components or hallucinations. All right, shifting to that, the last topic I'm going to talk about is how do we treat Parkinson's disease? So again, we have the motor symptoms and the non-motor symptoms, which I like to think of the non-motor symptoms are also very impactful, and they're sort of hidden beneath the surface. Unless you're not talking about them or being asked about them, you may not always realize they're from Parkinson's disease. And so there's lots of treatments and things that we have for non-motor symptoms. I'm going to focus more on the motor symptoms right now. So first of all, the kind of things that I use as sort of the guidelines for treatment is we have to recognize that treatment is really individualized. We need to educate you about what the goals of the treatment are, what are the potential side effects that you could experience, the fact that we may need to adjust medications or add medications over time, as this is a progressive disorder, but that it really is a team decision. It's discussion between your doctor and you about what symptoms you're experiencing and how we want to tackle that. And it's a combination of both medications and exercise. So we may be focusing on medicine for the rest of the talk, but we don't want to forget the very important piece, which is exercise, which is a huge part of Parkinson's treatment. And then the overall guiding principle is quality of life. So just because we can add more medications or take higher doses, what we really want to be the guiding light or the guiding principle is how this impacts your quality of life, and that's at the end of the day what we want to see improvement in. So medication options. So like we talked about, there's a lack of dopamine in the brain, and that's what we're trying to tackle and improve. So different ways that we can approach this is bump up the dopamine levels, and that's what carbidopa-levodopa does. Block enzymes that break down that dopamine and stimulate those dopamine receptors in different ways. So we'll kind of talk about each of these. So first of all, we have carbidopa-levodopa, and that's our gold standard best medication. And I've kind of made a little pictorial to show you why. So levodopa, that second drug of the carbidopa-levodopa, that gets broken down in our blood system. So that's a blood vessel that it's showing you there. And that gets metabolized into dopamine. So the body breaks it down into the chemical that we need. But what happens if that is broken down in the bloodstream and not the brain is that you can get side effects, and it doesn't get to where it needs to go. So we give it with this medicine called carbidopa, which stops it from being broken down in the bloodstream. Now, the great thing is that carbidopa doesn't cross the blood-brain barrier, but levodopa does. So levodopa then can get to the brain and then be metabolized and get to where it needs to go to turn into dopamine to get it to your brain so that it can have its effect. So that is why this Sinemet, this 2-drug combination, is always given. Now, typically with the onset of starting this medication, people may notice change in their symptoms, sometimes within hours or days, but typically within a week or two, you notice improvement in your symptoms. Now, some possible side effects include nausea. That's probably the most common side effect we see. We can see also lower blood pressure. Some people may develop sleepiness or abnormal dreams, and then hallucinations. Most Parkinson's disease medications can increase risk for hallucinations. As the disease progresses, we can see some other complication with Parkinson or with carbidopa-levodopa or Sinemet, in that the medicine doesn't quite last as long, and we need to redose the medication. And I call that kind of riding the roller coaster. So your body really notices, or your brain really notices, when those blood levels drop down, and then your symptoms get worse as the levels drop. And at the same time, we can also see the onset of these wiggly movements, which are called dyskinesias. Now, these two issues are very common in Parkinson's disease, and they do make it more complicated to use the carbidopa-levodopa. So we have different formulations that will help us kind of tackle these issues. We have the carbidopa-levodopa immediate release, and that's usually kind of our standard medications that most people take. It also comes in a continual release capsule or tablet that kind of sits in the stomach and is absorbed. We also have a version called extended release, or Rytari is the brand name, and that has capsules in these little pills that have both immediate and long acting, so that we can hopefully not have that roller coaster effect and have a longer benefit. We also have inhaled levodopa. I apologize because this inhaled levodopa called Ambrosia is just levodopa without the carbidopa. I mislabeled that. And then we also have infusions of levodopa that can give you a steady state throughout the day, and that is given through a feeding tube in the stomach. So those are just different ways that we can deliver carbidopa-levodopa to you. The next medication group are dopamine agonists, and how these work is they act on that dopamine receptor. So it's not that exact dopamine, but it still triggers that receptor to fire. So it may not do as quite efficiently as the levodopa or dopamine itself, but it still can do a fairly good job at reducing symptoms. And those are some of the different formulations that we have of that medication. The drawbacks of dopamine agonists is that they can have more side effects than carbidopa-levodopa, and over time, these side effects can accumulate and become more prominent as you age. So they're not my most favorite or my go-to medications in people older than 60 or 65. As you can see, they can have a higher risk for hallucinations, sleepiness, swelling in the legs, and a group of disorder called impulse control disorders, which is like gambling or spending money, that can be a direct cause from the medication itself. The advantage is that the dopamine agonists don't have as much of the dietary restrictions as carbidopa-levodopa, and they come in a long-acting form, so there is possible to do a once-a-day formulation compared to the multiple times a day that we have to do with carbidopa-levodopa. Another class of medications are, let's stop the enzymes that break down dopamine, and these are known as monoamine oxidase inhibitors or catecholaminetransferase transferesterase inhibitors. We will call these MAOB inhibitors and COMT inhibitors. And again, what they do is stop the breakdown of dopamine. So these medications have modest benefit. They're not as good as carbidopa-levodopa for sure. They're probably not as potent as the dopamine agonists, but they can help improve on time when people are having that wearing off, and sort of give a booster effect to the medication. The last drug that I'm going to talk about is called amantadine. Now, this isn't a comprehensive list of all the Parkinson's medications, but it's just a quick overview. Now, amantadine is actually an antiviral agent, so it was initially used for flu, and people with Parkinson's noticed that their symptoms got better, so it started being studied for Parkinson's disease. So we know that it improves off time, so it helps those motor fluctuations. It can also help reduce the dyskinesias. So that's the only medication that we have that we can give to somebody to help tampen down those wiggly movements that may become bothersome when we are using the carbidopa-levodopa. So, there's various treatments and therapies, non-medication things that we can do for the non-motor symptoms. So we'll hear a little bit more about that today, because the non-motor symptoms can also be very impactful. I just didn't have enough time to discuss those. And then I also just want to stress that exercise is a treatment for Parkinson's disease, but we'll have a talk about that. And just one more word about that is that we don't have any medications that can slow down the progression of Parkinson's, but exercise is probably the closest thing that we have to any evidence that it can slow the progression. So we talk a lot about medicines and pills, but exercise is also very important for the treatment of Parkinson's. All right, so with that, I'm going to be finishing up, and then I'm going to hand it off to Dr. Amy Hellman, who will be talking about sleep issues in Parkinson's disease. Thank you.
Good morning, everybody. When I'm done with my talk, we will have a 30-minute break, so I will do my best not to put you to sleep before that as we talk about sleep in Parkinson's. Just waiting for my slides. All right. Before I get into the specifics of how Parkinson's disease affects sleep, I'm going to talk a little bit about the importance of sleep in everybody. I think we all know and realize that we feel better when we get good sleep and have at least some sort of idea that it's important for our health, but it is extremely important for our overall health and our functioning from day to day. Insufficient sleep can contribute to many negative outcomes. So, of course, we can be drowsy during the day, which makes us less sharp and not enjoy ourselves as much, and also make just normal day-to-day functioning a little bit more difficult. With decreased alertness, we don't perform at our best. It also takes more effort to perform at our usual level. There's increased risk of accidents, injury, and death. One example of this is after time changes where we lose an hour of sleep, the following day there's more car accidents than any other day in the year. So this is just an evidence of how just that loss of 1 hour of sleep can decrease our ability to function at our best. There are detrimental effects to our psychosocial and physical health. So there's a greater risk of depression and anxiety with chronic loss of sleep. Cognitive impairment as well. Our brains do not work as well if they don't have good rest. It affects our cardiac health. So there's, again, very big risks to our physical health and well-being. There's immunosuppression, so we're more susceptible to infections. And there's an increased risk of obesity, which has, of course, other health effects associated with it. And there's also a measurable decreased quality of life in people who have chronic issues with sleep. When we talk about sufficient sleep, we're talking about two different components. So, of course, the duration of sleep, which is the quantity, but also the quality of our sleep, or the depth, how deep our sleep is. And there's the combination of the two that give you, the overall quality of your sleep, or the sufficiency, I should say, of your sleep. Sufficient sleep depends on not just the number of hours that you are sleeping. I'm sure everybody has experienced a time or two, or maybe several, where you get a good solid 8 hours of sleep, but you still wake up not feeling rested. And that's usually because the quality of sleep, the structure of your sleep, was not ideal. And there's a lot of things that can go into that. So sufficient sleep depends on the number of arousals, so how often you wake up or get near to waking up in sleep, and then the percentage, duration, and type of sleep stages. So I'll tell you just briefly about the stages of sleep. There are 5 stages of sleep. Phase 1 and 2 are the lighter stages that are You're kind of closer to wakefulness. Stage 3 and 4 are the deep restful stages of sleep. So these are the stages where there's a certain amount of that we need to really get that rest that's necessary. And then there's the rapid eye movement, or REM sleep. This is the stage in which we dream. What happens in REM sleep is there's a part of our brain that basically paralyzes everything except for our eyes, and that's why there's the rapid eye movements that occur while we dream. This is also why most of the time we don't act out our dreams. I'm sure everybody has seen a dog or a video of a dog running in their sleep, or even there's one where the dog is fast asleep and then jumps up and runs into a wall. It's because they're acting out their dreams. They don't have that same, what we call sleep atonia. Their brains don't paralyze them. We usually don't do that because of safety. Our brain keeps us from doing that. And even though REM sleep is a deeper stage of sleep, it's not the most restful. So again, you need a certain amount of that stage 3 and 4. And we cycle through these stages throughout the night. So you'll have, sometimes in stage 1, you might kind of wake up. So we call those arousals. You might not remember that. So because we are so close to sleep and they're very brief, a lot of times you can kind of just come to being awake and then fall back to sleep and not be aware that you have woken up many times throughout the night. So sleep is commonly affected by Parkinson's disease, and in different ways. Parkinson's can cause many types of sleep disorders. So these are sleep disorders that we can see in people without Parkinson's disease, but we see all of them more frequently in people with Parkinson's disease. The sleep effects can start years before the movement symptoms, and they can worsen as the disease progresses. The ones I'm going to talk about, these are the most common, are listed here, and I'll go through them one at a time, starting with insomnia. So about 80% of people with Parkinson's disease have insomnia at some point in their disease process. Insomnia can be difficulty falling asleep or difficulty staying asleep. So people fall asleep okay, but then they wake up and maybe have trouble falling back to sleep. Some people have what we call early awakening. So you sleep okay until maybe those very early hours of the morning, and then you wake up too soon and can't get back to sleep. And then for some people, it's a combination of those things. Overall, there's also a poor quality of sleep. So what we see is what we call fragmented sleep. So maybe throughout the course of the night, you get your 8 hours of sleep, but you have 3 hours, and then you wake up, and then you have another 3 hours, and then you wake up for a while, and then 2 hours. And because of that, that quality of sleep that's needed, that disrupted structure, it's not the same type of rest or same amount of rest, the same quality of sleep when it's fragmented that way. Anybody who's had a child who wakes up multiple times a night knows what we're talking about. The sleep can also be less deep, so again, less of that stage 3 and 4 sleep, more of the stage 1 and 2, and maybe even some more of the REM sleep. And some people will have a nocturnal tremor. So overall, when people fall asleep, the tremor will go away. But in those lighter stages, particularly stage 1 sleep, the tremor can come back out, and sometimes that's enough to wake people up or make it difficult for people to fall asleep. And insomnia can be aggravated by some of the medications we use to treat the motor symptoms in Parkinson's disease as well. So sometimes fixing one thing can disturb something else. Along those lines, some of the things that contribute to insomnia are those motor symptoms that occur at night, and even sometimes some of the non-motor symptoms of Parkinson's disease, if they're worse at night, or just maybe they're there during the day, but also at night, but you're not trying to sleep during the day. So this might be things like the tremor or other non-motor symptoms like anxiety. So there's various symptoms of the disease itself that can contribute to the insomnia. I mentioned anxiety, but depression, anxiety, and panic disorder can all cause or contribute to insomnia. These are all also very common in Parkinson's disease, as Dr. Woodward is going to talk about later, and they all affect the structure of sleep as well. So again, sometimes it makes people more tired and sleep more, but can affect the quality of sleep, can disrupt sleep, keep people from being able to fall asleep. So it has a big effect on, each of these things has a big effect on sleep. Urinary frequency is common in Parkinson's disease, especially at night. So again, this can cause sleep disruption where people have to get up multiple times in the middle of the night to fall back or to go to the bathroom, and sometimes people have a really difficult time falling back to sleep. Nocturnal leg cramps are very common, not just in Parkinson's disease, but in all people, and that can be it cause trouble falling asleep or wake people up from sleep. And again, as I mentioned, some of the medications that we use in Parkinson's disease can contribute to insomnia. We can help to manage insomnia by talking to your doctor about all of these things, any of these things that investigating if there are any of these things contributing to the insomnia and how we can treat those things. There's also, it's important to maintain what we call sleep hygiene. So this is a group of behaviors that, when done routinely and regularly, can help improve the quality and quantity of sleep. So it's actually kind of the first line treatment for people with insomnia, even in people without Parkinson's disease. I think I talk about that here, yes, and I'll talk about it now. So this includes having a regular sleep schedule, so going to bed at the same time each night and getting up at the same time each morning. This ensures that you have the same amount of sleep each night. The brain really likes routine. So the more you have this routine, the brain just starts to know this is the time that we go to sleep and this is the time that we wake up. And it might take some time to get into that routine, but maintaining that routine can really have a big impact on treating insomnia. Again, exercise, you're going to hear it a lot today, but exercising daily can help to treat insomnia. It's important, though, not to do it right before bedtime because that will get you activated and can make it harder to fall asleep. But doing it earlier in the day can help the quality and quantity of sleep at night. One part of the brain that, or not one physical part, but one system in the brain that regulates sleep and wake cycles uses light. So it's important to get a lot of exposure to light during the day and reduce your exposure to light at night. This will help, again, the brain know when it's time to be awake and when it's time to go to sleep. So, when the days are shorter, sometimes there are lights that can kind of mimic the type of light of sunlight, so UV lights that you can get that can be very helpful if you're not getting enough light during the day of the natural sunlight. But it's also important that you don't expose yourself to too much light, even artificial lights, if you're struggling with insomnia. So this contributes to some of the other things like don't watch TV at night, don't be on screens, give your brain kind of a break from the light so that it can start to shut down and realize it's time to go to sleep. And that's in this next one, sleep in a quiet and dark environment. It's really important too for the brain to associate your bed with sleep. So don't do anything else in bed. Don't even read in bed. Definitely don't watch TV in bed. Don't be on your phone in bed. Do all those things somewhere else. And when it's time to go to bed, that's when you go to your bed. Again, the brain just is a creature of habit. So if it knows, oh, this is where we go to bed, this is where I am, that means it's time to go to sleep, that will help. Then I talked about avoid looking at screens, avoiding caffeine after lunch. Some people are more sensitive to caffeine than others, so some people need to avoid it completely, but definitely later in the day. Sometimes a snack before bed can be helpful, but don't eat a big meal right before bed because that can actually make sleep worse. Avoid alcohol within 3 hours of bedtime. Even though alcohol can make you sleepy, it affects the quality of your sleep. So sometimes it's good even to avoid alcohol altogether if you're having a lot of trouble with sleep. Don't smoke, especially in the evenings. Do something relaxing. Have kind of a relaxing bedtime routine. Again, when you start it, you're telling your brain, okay, it's almost time to go to sleep, and so it knows to start kicking into that process. And I already talked about associating your bed with sleep. So those are that's the first step in anyone who's having trouble with sleep, is to start doing those things on a regular basis. And that can really, maybe not the first night, but once you start doing them as a routine, it can really improve the quality and the amount of sleep.